Hi, everybody. As promised, I am here with you live talking about addiction and recovery. So, welcome. I hope you get a lot out of this. We're just going to spend a little bit of time talking about addiction, what it is, what you can do to take care of yourself. So I'm a licensed marriage and family therapist, licensed since 2008, and I have been working in addiction and working with trauma and many mental health conditions, specializing in addiction, trauma, family systems, and also psychopharmacology. I'm an adjunct professor of psychopharmacology at Pepperdine, and I currently teach psychopharmacology, and I have also taught addiction in the past as well. Recovery is very familiar to many of us, and for those of us who know recovery, either from being in recovery or struggling to try to get there, we know it is quite a journey. There's a lot of pain and suffering. Addiction itself is a very heavy loaded term, one that carries a lot of shame and stigma. And, many decades ago, we really looked at it as a moral issue, as if there was something inherently wrong with you if you struggled with addiction. And today, we know that it is so much more than that. In fact, it's not a moral issue, but rather it is a disease of choice, as really the idea of coming from the medical model. In other words, it is a disease just like diabetes is. For example, one might not choose to have diabetes, but we might struggle with sugar intake. And so there are some choices that we make that may worsen the disease. So really what this means is that there is largely some genetic predisposition with respect to our genetics. Also, it is not just about substance use, chemical addictions, but it's also process-oriented addictions. We can become addicted to social media, to exercise, to food, to sex, to relationships, to gambling. And really, when we're talking about addiction, the same thing is happening in our brains chemically, regardless of whether or not it's a substance or a behavior. So I really like to think about addiction as behavior, but also what happens in the brain when we are struggling with addiction. There are two primary neurotransmitters that are strongly affected when we're talking about addiction, and that is dopamine. That's number one, and glutamate. And I'll give some examples of what I mean about that. So dopamine is considered our pleasure chemical, our pleasure neurotransmitter. In fact, we have the pleasure center in the limbic part of our brain. This is also where we have a pleasure threshold, if you will. So when we eat a piece of chocolate, we get excited and we hit that, ooh, this is really wonderful pleasure, right? Pleasurable experience. And then we come back down, and, when we're working, we're below that pleasure threshold, for example. Well, when we have a predisposition to addiction genetically, when we exceed that pleasure threshold, we get that dopamine hit, that dopamine burst from that substance or that behavior. then our brains tell us, oh, that's good. Let's repeat that, just like eating chocolate cake. So then we repeat that, and we continue to exceed that pleasure threshold. And then what used to be pleasurable is no longer pleasurable. And so that means that this is how tolerance develops, tolerance and dependence. So we will continue to take more of that substance in, or do more of that behavior to try to reach that same pleasurable experience that we used to get with the first 1, 2, or 3 times. So it takes more and more. And this also is what leads to what we know as anhedonia, loss of interest, loss of pleasure. So when we struggle with addiction, we are not finding anything pleasurable in the normal day-to-days, or even some of those special things. Even going for a walk in nature might just seem meh. And I think that's a pretty good term for it. Meh. Could care less. Not really finding pleasure in it. So it takes a great deal to get that same sensation, and that's how we get stuck in the loop of addiction. So we have, I'm just looking at some of my notes. You know, when we're talking about addiction, it's not just about genetics. It's also about adverse childhood experiences. In other words, different traumatic experiences that we might have had. It's also strongly connected to grief. Why is that? Because we want to escape the memories of trauma, or the current traumas, or the memories of grief, or the grief that we continue to carry, because grief never goes away. It stays with us. It just transforms over time. So I really see addiction as not just a disease of choice, actually. I really see it as a disease of suffering and a desire to escape and to feel better. And that's really what we do, is we try to feel better. Unfortunately, with addiction, even those behavioral addictions, we change our brain chemistry. So then when we aren't getting either that substance or that behavior, our brain chemistry is out of whack. So we recognize that we've been doing these things to feel better. And we want to feel better because we know it's not helping us to feel better. So we go on a journey of recovery. And that journey is very painful and can feel like a lifetime. When we first come off of any substance or stop any behavior, we go through what's called acute withdrawal. Specifically with substances, that's when the substance is leaving our system, right? Where our bodies are metabolizing it and excreting it. And depending on the substance will depend on how long it takes for it to get out of our system. So after acute withdrawal, we think, I should feel great, right? Wrong. In fact, that first month may feel great, might not, but a lot of people say after that first month, after that, getting through that first 30 days, I've done it, I feel great. Well, after that first 30 days, the brain chemistry begins to shift again. So what we have happening is what's called a dopamine dump. So our dopamine levels begin to return to normal within those first 30 days, but then they will dump again, just trying to shift. And we're also having shifting of glutamate as well. So it takes about 3 to 6 months on average, depending on the substance and the length of use, for our brain chemistry to begin to norm out. 1 year is sort of that beautiful golden mark for the most part, under certain circumstances. and it depends on what kind of treatment we're doing. So just to give you an example, for alcohol use, when we go through that acute withdrawal, we have a hangover. And when we drink alcohol, we're lowering our glutamate levels. Glutamate is our major excitatory neurotransmitter. So in other words, when we lower our glutamate levels, we are calming down and feeling better, right? That's that sedating sort of effect that we get with alcohol. Well, when alcohol leaves our system, we get that hangover, but then glutamate levels rise. Remember, it's our major excitatory neurotransmitter. So everything gets activated again. So then this is what we call post-acute withdrawal syndrome, known as PAWS, P-A-W-S. So these are after the these come in after the acute withdrawal. So this is where we experience insomnia, agitation, poor appetite, restlessness, mood swings, you name it, right? We're going through it. And that post-acute withdrawal is, depending on the substance, can be up to 2 years. If we're doing replacement therapies for substances like heroin or fentanyl, opiates in general, when we do replacement therapies, then we never really go through post-acute withdrawal because you're keeping your brain chemistry still in addiction, if you will. It's just a little bit different, and I can explain that. But before I do, let's just talk about the two primary models for treating addiction. We have pure abstinence, where you just stop and you are on a sober journey. The second and probably most now popular model, especially in light of the opiate epidemic, is called harm reduction. It's the harm reduction model. This is shows up in many shapes and sizes. If someone's using heroin, they stop using heroin, but they smoke cannabis. That falls under the harm reduction model. If somebody is an IV user, doing needle exchanges, healthy needle exchanges, right? Getting clean needles and using gloves and not sharing needles, that's part of the harm reduction model. Methadone and Suboxone are also part of the harm reduction model. These are replacement therapies that help reduce the level of harm that we cause ourselves. Some people, for example, with methadone may stay on methadone for their whole life. Some people may stay on Suboxone for their whole life, but the average amount of time is 5 years. So staying on a replacement therapy for about 5 years actually has the best outcomes for recovery if your long-term goal is abstinence. So what do we do? So I've talked about replacement therapies, and that is where you would see an addictionologist, a psychiatrist, go to a treatment center, and you can be prescribed certain medications to help you. There are other pharmacologic interventions that can be helpful. For example, naltrexone is useful for both opiate addiction and for alcohol use disorders as well. There's certain criteria for it, and of course they are by prescription. But basically the way they work is that they reduce the urges and cravings. And one of the most interesting things is that it attaches to the opiate receptors in our brain, and it blocks the signaling, if you will. It blocks the drug. So if one were to consume alcohol or take an opiate, it would block that drug from attaching to that opiate receptor. So there would be no or partial minimal response depending on the drug. So they can be very helpful. There are some other treatments like antidepressant therapy, for example. Wellbutrin is considered to be helpful for stimulant use disorders such as cocaine and methamphetamines. It is a more activating psychotropic, and it works on dopamine, and it is non-addictive, right? We don't develop a tolerance to it in the same way that we would with these other substances. There are newer therapies that are out there, like ketamine infusions that are by prescription only, and it depends on the type of addiction whether or not it would be a beneficial treatment, because it was originally created. It is a surgical anesthetic, but it was originally created to help with treatment-resistant depression. There is also MDMA, which is in the final stages of FDA approval, and that is for treatment of PTSD. So if we treat the root cause of what's causing our addiction, trauma, depression, grief, then we have a better chance at treating our addictions and really feeling better overall once those substances are out of our system. So we also have some other novel treatments like ibogaine that is being explored for treating opiate withdrawal. Lucimera is one of the newer FDA-approved drugs that helps with opiate withdrawal as well. Of course, if you do not already know, there's Narcan out there, which is a overdose reversal drug that works very quickly. It's a nasal spray. I recommend everybody having them if you know anybody or if you struggle yourself with opiate addiction. Fentanyl is a whole nother game, especially carfentanil, which is 1,000 times stronger than fentanyl and 10,000 times stronger than morphine, and a single grain can kill you. So do not, I highly recommend you do not try and go out using these novel treatments without a prescription and without professional guidance, because if you're getting anything on the street, it could be laced with anything and could lead to death, overdose and death. For example, MDMA, as I mentioned, is a novel treatment and is only administered in the clinic, and it's only needed 1 to 3 times typically. It is also known on the streets as Molly and ecstasy, and those oftentimes may not even contain any MDMA at all, so you're not getting any clinical benefit of it, and it's laced with so many different things, including amphetamines and very possibly fentanyl. So you could be risking new addictions and overdose and death, as I mentioned. So talk to a professional. Do your research. Make sure that you're not going out and self-medicating, because that is a very dangerous thing to do. Even mixing over-the-counter supplements with certain drugs can be dangerous. For example, if you're taking an antidepressant prescribed and you take a supplement over the counter like St. John's wort that treats depression, you could be risking serotonin syndrome, right? Too much serotonin. But vitamins, minerals, supplements are helpful, especially magnesium citrate, especially if you struggle with alcohol use disorder, because your magnesium is likely depleted, and that causes aches in your legs, difficulty sleeping. Magnesium's important for sleep. It's important for muscle, right? So if you're having a lot of cramping, that could be an indication that you have a magnesium deficiency. Omega-3 fish oils are wonderful for the brain. Our brain is mostly made of fat, so we want those good, healthy fats for our brains. Of course, vitamin C. Vitamin D is critical for our bones, for our mood, for our skin, and most people have a vitamin D deficiency. Exercise, of course, is so important in maintaining, in recovery, rather, and just for our bodies in general. And specifically, we're talking about somatic exercises when you're struggling with grief and trauma. So yoga is number one. Qigong, Tai Chi, those are all wonderful. Walking is wonderful. Being in nature, meditation. I've got to be here with me. Okay. So, what can you do? Also, you can do EMDR. Sound healing is really wonderful, especially using tuning forks. And then there's some energy-based practices that you can try. Sea salt bath. Take a sea salt bath, not Epsom salt, sea salt bath with some lavender essential oil. That really helps clean the energy body. It's a detoxifier. This is why when we go into the ocean and go swimming, we feel so refreshed when we come out. It's because of the sea salt. Specifically around meditation, do the Twin Hearts meditation. I can share that link online, and we'll do so. Also, we want to maybe do some energy chakra healing, specifically throat chakra, solar plexus chakra. This is where we hold a lot of our stress, but this is our power center. This is where we use our voice. And then our third eye. This is the center of our will. This is where our willpower comes from. And also our basic chakra. And this is our safety security center. This is about being grounded. So I want to thank you for joining me live today. We will perhaps meet again. I will do some meditations with you all. And actually, let's just take a couple of moments. Close your eyes. Taking a nice breath through your nose. Hold there. Exhale out through the nose or the mouth. Hold. And repeat. This is a wonderful breathing exercise that you can do that really can get you into a meditative state. It's called 6-3-6-3 breathing, pranayama. So you will inhale for 6, hold for 3, exhale for 6, hold for 3, and repeat. Anytime you need to gather yourself, ground yourself, manage that stress response in that limbic system here, go to 6-3-6-3 breathing. Maybe step outside barefoot, dig your feet, toes into the ground. Let's do some grounding. Thanks for joining me, everybody. Have a beautiful day.